So we're going to go ahead and get started. Thank you for coming to Grand Rounds. It is a distinct privilege and pleasure to introduce today's speaker, who's an old friend and colleague, Dr. Chris Whinney. Dr. Whinney is a native of Greater Philadelphia, a lifelong Eagles fan, and went to Catholic University for college, went to medical school at what was then the Medical College of Pennsylvania, and did his internal medicine training at Temple, so he certainly knows underserved populations. Dr. Whinney was briefly in private practice before we started working together in what was then the tiny section of hospital medicine within the division of general internal medicine at the Cleveland Clinic. Back in those days, we just were kind of making it up as we went, I would say, in the very early days of hospital medicine. But the group grew and grew, and Dr. Whinney took on positions of greater responsibility until he became the chair of that group in 2010, if I recall correctly.
That's correct.
And has continued to oversee and direct the massive growth, really, of the department there. They now have about 200 providers, seemingly add new service lines all the time. And Dr. Whinney has opened hospital medicine groups in most of the regional hospitals in the clinic system. In addition to his responsibilities in the clinic, he has been a leader in a number of ways in our specialty organization, the Society of Hospital Medicine. From a clinical standpoint, his real area of expertise is what we'll be talking about today, perioperative medicine. Dr. Whinney frequently speaks and publishes in this space. On a personal level, he is kind of a Renaissance guy. I won't go into kind of all of his other things he does besides medicine, but I will say that he is a serious CrossFit aficionado, and he is also the longtime bass player and booking agent for a semi-legendary Cleveland band called Squish. And I want to read a quote off the band's Facebook page.
Oh, good Lord.
Squish have been playing together since late 2002 when we cranked up the volume to astounding levels and haven't stopped since. The band is known for face-melting guitar solos, searing vocals, and rumbling bass undertones. And I have to say that despite wanting to see Squish for a long, long time, I've yet to see them. But Chris, that's still on my bucket list.
Sounds good.
So please give Dr. Whinney a warm welcome.
Thank you, Jim. I did not expect that. So you are always filled with surprises. So there will be no searing vocals or rumbling bass undertones today. Maybe a little bit, but we'll certainly talk perioperative medicine. So I want to thank you. Really, it's a pleasure to be here. First and foremost, we have to get the particulars out of the way. No financial relationship to disclose, no off-label use or investigational use in my presentation, except for this. I want to highlight this, that there's some trainees in the audience, and I trained at Temple University Hospital in Philadelphia when I had hair and I had glasses. And, I really feel, for several reasons, I have a kinship with MetroHealth because Temple and MetroHealth are very similar. We serve a safety net population of the patients that need us the most. And we really learn to trial by fire. You really learn to care for patients well. And I will highlight that as a department chair, we were just talking about this, that I've recruited and hired probably 40 physicians a year for the last 5 to 6 years. And anytime a MetroHealth resident's name comes up, there's a warm feeling of comfort that knowing that that person is eminently well trained. And I'm not making that up. That is the truth. So thank you for all you've done in training great doctors here. So from the Periop standpoint, I will do a little bit of a Periop 101 as well as a 201. For those who are familiar with ACC/AHA guidelines, I will go through that, but we'll try and make sure we cover that. Concept of MINS, myocardial injury after non-cardiac surgery, and the selective use of biomarkers. We'll talk some about risk reduction strategies, including something called the MANAGE trial, as well as looking at postoperative pulmonary complications and management of cardiac and other medications, specifically ACE inhibitors, prior to elective non-cardiac surgery. So this is the angry surgeon slide. Anybody had an interaction with this surgeon? So he's got a 75-year-old with type 2 diabetes on insulin, last A1C of 7, hypertension and CKD, serum creatinine greater than is at 2.2, prior stroke without residual deficits. This patient fell in the kitchen and had a left femoral fracture. Prior history of limited functional capacity, but no specific dyspnea on exertion or chest pain. You see the medications listed there. And your orthopedic surgeon asks the ever-popular question in perioperative medicine, is she cleared? So your multiple choices are, and we'll do the old school audience response system. Cancel the surgery, refer to cardiology. Okay, good. Dobutamine stress echo. Cardiac cath. Who wants an EKG and proceed to surgery on extended release metoprolol 100 milligrams starting now? And everybody know why I asked that question? We'll get to that. Who wants the EKG and then proceed to surgery? All right, it's good. So majority answer, good choices. You may recognize the things I have in yellow there, right? The RCRI criteria, revised cardiac risk index criteria. So those are things certainly to keep in mind as we go forward. So, we use this term clearance, cleared, and it drives perioperative medicine providers nuts because it has that tacit implication that zero complications will occur at the time of surgery and through the surgical milieu. We all know that that can't happen. You can't guarantee that. So that's the term we use, optimize. In fact, we had a poster, I believe, Frank Machota, Amir Jaffer, and colleagues, and I don't know if you were on that or not, Jim, but the poster that talked about the analogy of the plane flight, which is why I have a great scene from Airplane, as well as the Princess Juliana Airport in the Virgin Islands, where people get to see planes landing a few feet in front on top of them. They do wear ear protection, by the way. But the concept is that the surgical episode, the surgery, is a plane flight, and the patient is a plane. The pilot, who would the pilot be? Be the surgeon, right? The co-pilot would be, naturally, the anesthesiologist. And so the internist is at the top right. This is the internist. The specialist is the mechanic to make sure that that plane is in its optimal flying state. So that's the concept that's important here to say, is this plane in its optimal flying state? We're not going to cure the patient of diabetes. Can we make sure that the glycemic control is adequate? We're not going to cure their hypertension, but we're going to make sure that their blood pressure is within a reasonable range for surgery. And so you'll hear me talk about the clinic tests, which means that in perioperative medicine, if you would have done this for a patient in your clinic, regardless of whether they were going for surgery or not, the general rule in perioperative medicine is that that's what you would do. If you would not do something to intervene on a patient in your outpatient clinic, then you should not do that in the perioperative period. And of course, the ACC-AHA guidelines specifically state no test should be performed unless it's likely to influence patient management. Now that becomes a gray area, but that's something that we should keep in mind, is that how our decisions and tests and procedures I'm going to order change the management of my patient. The ACC-AHA guidelines through several different iterations talk about communication. George Bernard Shaw said the big myth about communication is to assume it actually occurred. So making sure you communicate. We have the luxury at the clinic, in our what's called our impact center, to have our anesthesiologist literally next door. So if I have an anesthesia-related question, malignant hyperthermia, difficult airway, I will go next door and talk to them. Or if I have coronary disease or a significant risk concern, I will go and talk to them. Again, engaging the patient, shared decision-making, providing clear, understandable information about perioperative, cardiac, and other risk in the context of the overall risk of surgery. Many of you are familiar with this guideline. If you haven't seen this, we'll zoom in on it quite a bit. It's the ever popular ACC-AHA guideline. This actually, from the 2002 versions until now, has been simplified quite a bit. So if you think this is bad, you should have seen it then. But the first step really is patients getting surgery. Start to assess risk. We'll talk, RCRI and NSQIP are two popular tools that we use. If the patient's having emergent surgery, meaning they're going to die from the condition for which they need surgery, they need to go on the surgery and post-operatively you risk stratify. The second question is, are they having an acute coronary syndrome? That kind of takes priority over elective surgery. So you take care of the acute coronary syndrome according to goal-directed medical therapy. If you do not believe they're having an acute coronary syndrome, then you go down the path of assessing their risk. And so this is the ever-popular revised cardiac risk index. Sorry about the contrast on this. This is an externally validated tool that Tom Lee published in 1999 that highlighted several different cardiac outcomes that were relevant. It is easy to use and understand. It has 6 predictors. One is the type of surgery, which is intraperitoneal, intrathoracic, or suprainguinal vascular. And the others are the clinical conditions, which involve ischemic heart disease, congestive heart failure clinically, cerebrovascular disease, diabetes on insulin, and then serum creatinine greater than 2 pre-op chronic kidney disease. So they derived this and validated this in a cohort of about 4,000 patients. And you can see that risk for cardiac events is described on the left side of the screen. goes up significantly as you accumulate RCRI classes. So 3+, the right column is our patient who has 3 of those revised cardiac risk. The key thing about this is this is not validated for lower risk surgeries. So when you have a patient going for a lower risk surgery, either endoscopic procedure, superficial procedure, breast surgery, this is not something that has greater applicability to that. The other is ACS-NSQIP, or is anyone in the room utilizing ACS-NSQIP? So are you familiar with this? So some of you are, good. So this is not also a very unique tool that the National Surgical Quality Improvement Project has developed over hundreds of thousands of patients and is available online. It is not externally validated, but it does have significant numbers of surgical types to give you more granular information. So you can plug in the procedure, you can plug in the functional status, ASA classification, and comorbidities. And you can get a document like this, which is really helpful because then it gives you a panel of outcomes, not simply cardiac, that also can be printed in a PDF, and then you can bring it to the patient for a shared decision-making opportunity. To say, Mrs. Jones, we know you're elderly, you know you have this fracture, here is the risk of what might happen with you in terms of everything from return to OR, infections, death, and going to a nursing or rehab facility. So shared decision-making. Let's go back to the ACC-AHA guidelines. We talked about, let's estimate perioperative risk of MACE, major adverse cardiac events, based on the combined clinical and surgical risk. So if you have a patient that is at low risk, which is defined as less than 1%, go right ahead, pass go, collect $200, off to surgery, post-operatively risk stratify. If somebody is elevated risk or going for an elevated risk procedure, then you go down the route of assessing functional capacity. And we'll talk about that because some new literature came out, which we call the MET study, which I'll talk about. So anybody know what a MET is other than a baseball player in New York? Any votes? So metabolic equivalent, I'll give you a definition of a metabolic equivalent. It's the maximal oxygen uptake of a 70-kilogram male at rest, 3.5 mLs per kg. So that essentially, multiples of that are correlated with activity. And so the issue is a patient able to achieve our ever popular line of 4 metabolic equivalents of activity? If somebody's excellent functional capacity, they can run marathons, they do physical activity, off they go to no further testing, proceed to surgery. Moderate to good, it's also no further testing, class 2B recommendation, still off to surgery. If the patient is not able to do that or is unknown, and this is a classic state where you've got a patient with degenerative joint disease and going for a total hip or total knee, right? They don't get a pass for having arthritis as a limitation to their activity. If they're limited in their activity, they're limited in their activity. So the next step is functional capacity. And so this comes from Flatkey in the American Journal of Cardiology in 1989 that essentially correlated this with maximal oxygen uptake by exercise testing. And so that's why we get to that level of, can you climb up a flight of stairs or walk up a hill? And so that's, and that's a nuanced question to ask in practical terms, because I can tell you that I'll have the male patient sitting there who's getting the surgery, and he's nodding his head yes, and the wife is standing by him and is going like this. So correlating that certainly with the what the patient can do. I've had providers who have actually taken the patient out of the pre-op clinic, walked them up the stairs and down the stairs, and ascertained if they actually are able to do that without dyspnea or chest discomfort. So Daminder Vijay Sundra actually published this in looking at a more robust assessment of functional capacity in the MET study here. So this actually looked at comparing cardiac risk assessment using clinical gestalt in terms of functional capacity. Is like sort of formats, sort of not formats, cardiopulmonary exercise testing using the structured Duke Activity Status Index, and then serum NT-proBNP as part of that. So they used 25 hospitals, over 1,400 patients older than 40, outcome of death or MI in 30 days post-op, as well as a secondary outcome of death in 1 year. They did find a perioperative MI rate of about 2%. And this is what the Duke Activity Status Index looked like. So it's weighted scores on the right there. And essentially, the original Duke Activity Status Index, I didn't show that graph, but these do roughly correlate as you go up in terms of those that mathematical scoring system with the activity, with their VO2 max, essentially. And so subjective assessment in the MET study had a very low sensitivity and a high specificity. It did not accurately identify patients with poor cardiopulmonary reserve or predict outcomes. Cardiac exercise testing did interestingly predict post-op pulmonary complications and infections, specifically surgical site infections, but not cardiac events. And the Duke Activity Status Index actually best predicted both the first and second outcomes, which is the 30-day and 1-year mortalities. BNP did predict 30-day death and myocardial injury at 1 year. So the thought was that the DASI was the best tool to use in terms of using an objective measure for preoperative assessment as opposed to your subjective assessment. It's unclear if there's a combination of these that are actually useful. Do you combine DASI with the pre-op BNP? And should cardiac pulmonary exercise testing be utilized in terms of post-op pulmonary complications or infections, which actually in absolute numbers are much higher than cardiac complications. So that's something to keep in mind, that we all worry about the cardiac complications, but post-pulmonary and infectious complications are actually more frequent. So let's go back to AHA. So if there's that popular question of poor or unknown function capacity, will further testing impact decision-making or perioperative care? If that answer is yes, then stress testing. If abnormal, revascularize according to guidelines. This is a challenging one in practice because, you know, the question is are you going down the path of stress tests, abnormality, cardiac cath, intervention, with the assumption that revascularization will improve outcomes? So we'll talk about testing first, and we'll get back to that question. So if you're going to test the butamine echo or myocardial perfusion imaging in the perioperative period are essentially equivalent. They all have very high negative predictive values if they're normal. If there are moderate to large areas of ischemia, that does confer a higher risk. And the presence of an old MI or scar on non-invasive testing has little predictive value. For the exercise portion, if they're able to exercise, that's great. You need to achieve a target heart rate. And the popular double product can be used when that product of heart rate and pressure can be a tool that the anesthesiologist will use to maintain that below a certain threshold if ischemia is noted. And you do not specifically need imaging if baseline ECG is normal. For pharmacologic stress testing, which is probably more of your patients if they're unable to exercise, butamine echoes do have fewer false positives, but you do need to reach a target heart rate. If there is a left bundle, diprotamol, adenosine, or regadenoson, nuclear studies are better because you get some paradoxical septal motion on the butamine echo. That is the challenge. Still to this day, cardiac CTA, we still don't know what to do with those because though they are not on the armamentarium of preoperative testing. I believe that Dr. Devereaux, who was the lead author of POISE, is looking into some opportunities there as to how do you leverage cardiac CTA. It's a lot of radiation, so that's what we have to figure out. So that's kind of the 101 portion. Let's jump into, this is a more interesting portion, the 201 level, if you will. This is a 70-year-old male, underwent partial thyroidectomy for a malignant nodule, is now postoperative day 1. There are the comorbidities, all the great comorbidities you typically see in your perioperative patients here, I'm sure. Not symptomatic with chest pain or dyspnea. Multiple PVCs were noted, a little hyperglycemic, so needs some insulin adjustment. Because of the PVCs, the on-call resident ordered a troponin T that was 0.1 with a level of less than 0.02 normal. So let's ask the first question in this series of 2 questions. What is the estimated risk of 30-day mortality in this patient? Who's going to vote for A? 0.1, 1 in 1,000. 0.5%. 0.1, 0.5s? Okay. 1.4, 2.2, and 9.3. Anyone 9.3? Okay, before I answer that question, based on the available evidence, same case, based on the available evidence, what is the best course of action for inpatient management? Do nothing. This is benign troponinemia related to surgery. Beta blocker, aspirin, ACE, statin as tolerated. Medical therapy plus full dose unfractionated heparin. Anyone for A? B? Okay, few Bs. C, unfractionated heparin. Anyone with dabigatran? There's a reason why I have dabigatran in there. And E, urgent cardiac cath and intervention. So your best answer for one is 9.3%. So this is not benign. This is something that we need to pay attention to. And the best answer at this point, and I have two answers kind of highlighted. My best answer would be B. I highlighted D for dabigatran because this is what we'll get into the managed trial. I'm not entirely convinced about that at this point. I think there's still more that we have to do for that. But let's talk about it. This is what we call myocardial injury and non-cardiac surgery, so biomarkers. So 300 million surgeries annually, 1 out of 30 adults is getting surgery. More than 10 million experience serious cardiac events after non-cardiac surgery, 1 in every 6 to 800. More than 1 million adults die within 30 days of non-cardiac surgery. And the way Devereaux typically phrases this is that 30-day post-op mortality is 1% in the U.S. and 2% among inpatients. This would be the third leading cause of death if this were considered a disease. And myocardial injury is the most common cause of death during 30 days after non-cardiac surgery, but it's not just death, morbidity, length of stay, costs, and long-term prognosis. So our gentleman in the bottom left there, he's very optimistic, but needs to be careful. So the interesting thing about MINS is this idea that it can be an asymptomatic, flying under the radar. Only 14% of patients who are experiencing a perioperative MI or a perioperative event like this will have chest pain. 65% are entirely clinically silent, meaning there's no arrhythmia or other things going on there. So MINS definition is a fourth-generation troponin greater than 0.03 judged due to ischemia within 30 days after non-cardiac surgery. And so let's talk about what that looks like. So this is what's called the VISION trial. This was published in 2012 by the McMaster Group. This is 15,000 patients who underwent non-cardiac surgery and had a fourth-generation troponin determination drawn. And this was independently associated with 3 to 4-fold excess of 30-day mortality. As you can see on the graph there, where it's boxed, that's 0.3 to 0.29, about 9.3%. You can see that risk, if the troponin is greater than 0.3, can be as high as 16 to 17% at 30 days after surgery. And the combination event of non-fatal cardiac arrest, heart failure, CVA, and death is upwards of 20%. And so this is something that's real and something that's significant and something we need to pay attention to. We'll get into what we can do about that later on. But again, we found that people who have this event, their average time to death is between 6 and 9 days. So the question is, what do we have to do to intervene? And again, multiple studies, and this is just a series of a number of different studies, including POISE and others that looked at postoperative troponin. And the bottom line with this summary of studies is that higher rates of mortality postoperatively are seen with troponin elevation. It correlates with the degree of troponin elevation. And I want to highlight that this has been found regardless of the fact that they have renal disease or not. And we'll talk about the delta of troponin high sensitivity in just a second with the VISION study that looked at high sensitivity troponins in the subsequent study in JAMA. This was a prospective cohort study that looked at that high sensitivity assay. You can find that out of 1.2% of deaths overall, this is what it looks like in terms of the mortality as you go up with that high sensitivity troponin threshold growing above 1,000. So the mortality of almost 30% and a hazard ratio of 227 if you have that increase in that troponin T. Now, you look at the absolute change in troponin greater than 5 nanograms per ml, also had a hazard ratio almost 5 for mortality post-op. And even without ischemic symptoms, the hazard ratio was high, and highlighting the fact that in the study, 93% of folks with that MINS diagnosis did not have symptoms. So ACC-HA previously said, you know, it's certainly something to think about, but the usefulness of screening with troponin is uncertain in the absence of established risks and benefits of a defined management strategy. What do we do about this? That's why they said routine postoperative screening not useful for guiding management. But again, but now they've pivoted. The recent fourth universal definition of MI does suggest postoperative troponin surveillance is recommended for high-risk individual. However, we still need to call it an MI. We still need evidence of ischemia. We still need to establish a baseline preoperative value to see if this is acute or chronic and to trend it. If it's not considered an MI, they're calling that acute myocardial injury, especially after non-cardiac surgery. So again, what can we do about this? We'll get into some strategies of what we go down. The ever popular, well, do we intervene? In every other patient, we intervene with a PCI or CABG. The two studies that really highlight this, saying that does revascularization reduce the outcomes, the potential for a bad outcome. The CARP trial in 2004 was McFall's 18 VA centers, about 510 patients of stable cardiac disease undergoing elective vascular surgery, randomized to medical therapy alone versus revascularization. And you can see the rates of 30-day MI, death, or long-term mortality, 22 versus 23%. So that was a sick group that 1 in 4 to 1 in 5 died. But they did find that if you looked at subgroup analysis of CARP, CABG was about 60-40 CABG to PCI. CABG group did do better with specific benefit for patients with left main disease. I will talk about the DECREASE-5 study, but I have stars beside that for a very good reason. And any of you familiar with the researcher Don Poldermans from Erasmus University in the Netherlands will talk about why this is an asterisk. They had a very large group at Erasmus University that did a ton of perioperative studies over the last prior decade. And DECREASE-5 looked at patients with an abnormal dobutamine echo, 5 segments or more, and that's a lot of ischemia, and essentially randomized them going for vascular surgery. And many of these studies use vascular surgery as the surgery of choice because there's a higher rate of events with vascular surgery because they're vasculopaths for the most part, and they're going to be more likely to have events, so you need fewer patients to get the power. So they did find that there was no difference in 30-day MI, death, or long-term mortality in that group that otherwise was a very sick group with medical management. If they were previously revascularized, there is a potential benefit. The Cath study tells us that revascularization gives you 4 to 6 years of kind of cardioprotection. However, the problem is this has not yet been studied in MINS, particularly in terms of revascularization. And again, I bring back that clinic test. Would I treat or intervene this person regardless of the surgical milieu? Medical therapy, so what about beta blockers, right? Beta blockers, this could be an entire hour talk on beta blockers, so I will try to summarize this as best I can. I will cite that there has been a tremendous pendulum of beta blocker opinions over 30 years. It really started with 1996 in Mangano's MCSPI study in the New England Journal that found that 7 days of atenolol and before surgery and 30 days after led to mortality improvements at 2 years. How that physiologically works, I haven't figured that out yet, but a pendulum of opinions where it said that let's start putting beta blockers in the water supply to the point where we started having some negative studies led to POISE. And POISE was, again, one of the landmark studies that essentially said let's take beta blocker naive patients and start them on metoprolol XL, or ER, 200 milligrams as opposed to placebo, and let's see what happens. And I'm oversimplifying, of course, but they did find lower cardiac mortality and MI rate, but it shouldn't be surprising to this group that you found higher overall mortality, 3.1 versus 2.3%, as well as double the rate of stroke and significant deaths from sepsis. Right? Now, how many of you have prescribed metoprolol ER 200 milligrams de novo to a beta blocker naive patient? All right, good. Just making sure that probably not a good thing to do. Many of you will probably start 25 or 50 milligrams and titrate that up over time. And so this was based on a prior trial called the COMMIT trial, which was patients with acute myocardial infarction who got an equipotent dose of atenolol, which is 100 milligrams. So that's why we had the super high dose in the multiple choice question to stimulate your thinking, but also recognize that POISE basically tells me if we overdose people with beta blockers, they're going to stroke out and die more, but we'll save them from a cardiac standpoint. So it's not to say that this is where the Poldermans group, and I will get back to Don Poldermans, who was kind of an interesting kind of an arch enemy of Devereaux, who ultimately, Poldermans was found to be guilty of scientific misconduct and fraud. So all of his articles that I cited in the previous study here in DECREASE have been kind of taken off the radar. They're still commented on in the literature, in the body of the text of ACCHA, but that stuff pretty much has been taken off of any recommendations. So, but getting back to this, so the thing that Poldermans did bring to the table was the idea of starting a low dose and titrating over time, which is what you would do in practice anyway. And this is the issue of what this POISE really tells us is that starting a beta blocker the day before surgery, when many of us wind up seeing these patients in consultation, is not going to provide benefit and may provide harm. If you have the time, and you would do it anyway, getting back to the clinic test, you would get that beta blocker started low dose and titrate up as much as possible. If you get it to low dose and you titrate it once and you go from 25 to 50, are you affecting outcomes with that? I really don't know. You may be treating yourself as much as you're treating the patient. I think we've still got a lot of work to do in this space to figure that out. So other medical therapy includes POISE 2, which we highlighted aspirin and clonidine. Now, this was aspirin clonidine in a 2x2 factorial design that they said, let's look and see, because clonidine has some literature prior to this in terms of cardioprotection. And aspirin, we obviously know from CABG patients there's a benefit, but is there a primary preventive opportunity with patients getting aspirin? Lots of surgeons, as you know, are willing to operate on aspirin for different indications, with the exception of maybe neurosurgery. But does it benefit? And so POISE basically demonstrated, of course, you see more bleeding with aspirin, hypotension and bradycardia with clonidine, but we did not see any benefit in terms of cardiac risk reduction. So these are not strategies we would use. However, the subgroup analysis came out last year in Annals cited that essentially starting aspirin is of benefit to patients with prior PCI, which is a no-duh moment to me, because shouldn't that be a patient population that should be on this anyway? So that's where we stand in terms of medical therapy. This is a study from one French hospital that looked at patients with elevated troponins and escalated their therapy, which I think is where we should be going with this, to say antiplatelet agent, beta blocker, and statins were increased, 3 drugs or more, intensification. So the IT is intensification of therapy. So patients in blue had perioperative MI and had intensification of therapy compared to the line in red where they did not get intensified therapy. So clearly about a 40% lower event-free survival with intensification of therapy. So medical therapy does seem to work. Again, one small center, multi-center trial definitely needed. So from a beta blocker standpoint, class 1, give them if they're already taking them. The beta blocker withdrawal is something that is something we need to worry about. The same is true with aspirin and statins if they're already taking it for a separate indication. Give them selectively, high-risk patients and or high risk of vascular surgery. Start early and titrate the dose if possible, because that's what we do in practice. Bisoprolol or atenolol tend to be preferred over metoprolol, although we're not sure if this is a class effect. Titration of heart rate to make sure you're watching for bradycardia and hypotension. And then avoidance in things like patients who are low risk, because they're not going to get the differential benefit. The elderly, maybe they have chronotropic incompetence, prior strokes, sepsis, and emergent surgery, because you're not going to get that benefit. From the sepsis standpoint, sepsis was a subgroup that was harmed and had higher mortality in POISE. So let's go to the ever popular managed trial. So this is where we said, well, what do we do about this? So Devereaux and the crew at McNesser simply said, let's ascertain if we are able to reduce the risk. Why they chose dabigatran, I think there was a funding opportunity there. I think that there's a physiologic idea of, are you providing a novel anticoagulant that can help with thrombus formation in some way? So essentially this turned out to be a randomized trial of patients diagnosed with MINS. They're randomized to a 2x2 factorial design, dabigatran or placebo, and then the factorial design was with omeprazole and placebo, with the idea that if dabigatran is leading to upper GI bleed, are you able to mitigate that with the omeprazole? So the primary composite outcome was vascular mortality, the non-fatal MI, stroke, peripheral arterial clot, and symptomatic PE. And they did find that the hazard ratio was 0.72, which was statistically significant, meaning a 28% lower risk of the primary composite outcome. There are tremendous caveats with the study, which means that number one, they planned about 3,200 patients initially, and the funding was curtailed, and they only got about half of those patients. And they added in the middle of the study, because of the lack of recruitment, added amputation and symptomatic proximal DVT, their primary efficacy outcome in mid-trial. In addition, there's about a 46% discontinuation rate of dabigatran and about a 43% placebo. So obviously that makes it challenging to say in real life, is this going to be applicable if you've got that rate of discontinuation? And actually, Devereaux actually gave a fair explanation of that when he gave a talk at the Cleveland Clinic last week, and actually gave a fair explanation of that there was a public outcry over the cardiac risks of dabigatran, and I think a lot of patients heard that anecdotally and stopped it, and so they didn't know what they were on. They said, I'm getting out of the study, and stopped it. So this study doesn't necessarily get us in that right direction. What we do know is that the only secondary efficacy outcome to benefit was non-hemorrhagic stroke. So is this one of those trials where you put all the outcome data together, and is it really going to affect, your decision making here? So I'm not convinced from manage at this point. So what do we do? Frequent vital signs, put them in a monitor setting, look for the things, ischemia that we all know, optimize intravascular volume and glucose, educate the patient regarding future risks. This is a teachable moment. I don't know how the conversation will go. You just had a MINS as opposed to an MI or heart attack. I think we're still working out the language of how you tell that to patients. But clearly it's an opportunity for lifestyle changes, all the things that a good internist will do. And I think it's also a teachable moment for our surgical colleagues to make sure that we are awakening the severity of MINS. Call internists, call cardiologists sooner so that we can get on board and make sure we're doing the things we need to do. And so on the horizon, so this is the 301 level, is that POISE 3 is coming. And this is about a 10,000 patient multi-center RCT looking at bleeding risk and mitigating that with tranexamic acid infusions versus placebo. So this will be interesting. And the other side to that is the second portion of the 2x2 factorial design of this will be a perioperative hypotension avoidance versus hypertension avoidance strategy. And so what that essentially in a nutshell will be is that hypotension avoidance will be don't take any of your blood pressure medicines on the morning of surgery, off you go. And the hypertension avoidance is take all of your blood pressure medicines, including your ACEs and your diuretics on the morning of surgery, and let's see what happens. So the hypotension avoidance is actually a graded. If they're on a beta blocker, they'll get it within certain parameters, and if they have a blood pressure that's even higher, they'll get doses of their other medicines in a stepwise fashion. So it'll be interesting to see, and those are the outcomes they're going to look at, typical outcomes. I'm going to stop there. Do you want me to go through the rest before I ask questions, or what are we doing? 10 minutes? Okay. So let's talk about pulmonary risk assessment and risk reduction. This is a 68-year-old female presenting to you for pre-op assessment prior to right hemicolectomy. No known lung pathology, but 40-pack-year tobacco use history. Quit smoking 2 weeks ago due to a URI. Limited functional capacity due to degenerative joint disease and no recent PFTs. The question is, what is her risk for postoperative respiratory failure? Anyone for A, 1 to 5%, 5 to 10%, 12 to 15%, 20%, and 50%. Wow. Okay, so the best answer here is actually it's fairly low. For this patient, it's 1 to 5%. So PPCs are important, and we'll end after the PPCs discussion here. The second most common postoperative complication. It's categorized by atelectasis, pneumonia, respiratory failure, and exacerbation of chronic lung disease. It is associated with poor outcomes and longer hospital stays and increased mortality, and it does have better prediction of outcomes than cardiac complications. The ever-popular Arizona Index was created in 2001 for pneumonia, 2003 for respiratory failure, and updated in 2007. Essentially takes this preoperative panel of risks and assigns point values to them in a logistic regression model. Our patient falls into those categories with COPD listed there. The functional status is actually a much higher predictor in this tool, total dependent functional status, age, and type of surgery, especially closer to the diaphragm. And so our patient falls in the risk of about 1.2% risk of pneumonia and 2.2% of respiratory failure. Again, surgical type, age, dependence, and ADLs, smoking, COPD, and emergent surgery are less predictive. We also have the NSQIP index. This is similar to the cardiac index and actually looked at respiratory failure, meaning reintubation, mechanical ventilation. 5 main risk factors there. Strongest predictors are surgical type and preoperative sepsis. Again, great opportunity for shared decision making because you can present this to the patient. We'll talk about the ARISCAT index, which is a retrospective model that was prospectively validated and found about a 5% rate of events and at a 20% rate of 30-day mortality with postoperative pulmonary complications. And so that had 7 independent predictors, very high ROC area under the curve, including preoperative anemia, upper abdominal and intrathoracic surgery, duration, and emergent surgery are key areas that are contributed to that. And finally, the JAMA surgery had a recent study that looked at this, a prospective observational study of abdominal ortho and neuro procedures, and found that for folks with a ASA class of 3, non-cardiac surgery greater than 2 hours undergoing general anesthesia, about a third of these folks had PPCs. And they were all tied to early post-op mortality, ICU admission, and length of stay. Even atelectasis was a contributor to that. Duration of surgery, estimated blood loss, which are questions I often ask by surgeons, emergency were contributors. Colloid use, actually, interestingly, was a contributor. Tidal volume intra-op, that's why obviously lower tidal volumes are something that's important. And regional anesthesia, interesting, was associated. Now, whether that's a confounder based on you're going to choose regional in a patient that's higher risk may be the case. So bottom line is poor functional status, procedure type, comorbidities including age, COPD, and tobacco. So a quick word about sleep apnea, and we'll end here. Multiple studies show that it increases risk for PPCs and mortality. It's worse if it's undiagnosed. One of the scariest patients I have is the one I haven't seen a doctor in 30 years. Stop bang is the tool we use. Some suggest, Francis Chung, who's a leader in this space, suggests using serum bicarbonate as another tool. It's almost, she considers it the A1C of obstructive sleep apnea. But clearly we need to document, identify these folks, talk to anesthesia about regional techniques, non-supine position, obviously monitor them, minimize opioids and sedatives, and make sure they bring their CPAP machine with them. So I am going to stop there, and PPC risk reduction. Anything works better than nothing. Selective NG decompression, and, you know, again, have a conversation with your anesthesiologist. We are not anesthesiologists. So I'm going to stop there, and I'll take any questions.
Is there anything proven to lower the mortality as opposed to having a reaction to having caring for the patient after they have the operation?
Okay, so your question is, if you're seeing the patient in the hospital 3 hours before surgery or 5 hours before surgery, are you affecting mortality and outcomes in that patient? That's a little hard to say because you know, it depends on the patient. I think that you don't have a lot of time to work with that. I think that probably the biggest thing you can affect mortality is if you identify something that is a high-risk situation, either they're having ischemic changes or they have a condition that would affect the surgical milieu, you pick up the phone and you call, and maybe you actually defer that surgery. So, you know, if the patient is not optimized for a good reason, that's how you would affect outcomes. And I've done that. You pick up the phone and call. Pick up that phone and call the surgeon, call the anesthesiologist. If you're afraid that the surgeon's going to chew your head off, pick up the phone, call the anesthesiologist first and say, I talked to anesthesia, because they're not going to operate without anesthesia.
We get
That's a problem.
We get a lot of requests to give permission for our patients to stop taking their aspirin and their clopidogrel prior to going for all kinds of surgery. Sometimes it seems like it's pretty low-risk bleeding kind of surgery, and it seems that with the increasing evidence of risk for these patients to have a perioperative ischemic event, that's even more in favor of our pushing to keep those antiplatelet agents going. How much evidence is there that there is an significantly increased risk of bleeding with various types of surgery if those antiplatelet drugs are continued?
So there is an increased risk of bleeding. This is the scale we have to weigh here. The updated guidelines in terms of antiplatelet, especially dual antiplatelet agents for drug-eluting stents and interventions, it used to be a year, but they're now saying that 6-month window is appropriate. 3 months if risk-benefit really favors getting the procedure done. Elective surgeries, that's a conversation. The reason why they're on dual antiplatelet therapy is because of a recent stent. Then that is absolutely a conversation. You say either do it on this thing or defer the procedure until the window is out. I will say that more recent stents have less thrombotic activity than the earlier generation stents, But again, it's still a conversation to have because a stent thrombosis is a bad thing.
Yeah, I'm just thinking even longer term than that, because certainly there's agreement that one doesn't want to interrupt the antiplatelet drugs early. But suppose we have a patient who has a stent several years ago. I'm still concerned about them.
Sure.
And their increased risk. And you know, if they're going to have a tooth extraction, my goodness, you know, I basically tell the dentist, no, they can continue taking that and their warfarin. But it's it would be helpful for us to have a measure, a data that would really help us to balance the degree of risk from the bleeding for various kinds of surgery. And I was just wondering if there was anything like that out there.
Well, there are validated scoring systems specifically for GI bleed that you can use. From an antiplatelet standpoint, I'm not familiar with specifically antiplatelet type scoring systems. What we do is dual antiplatelet therapy, obviously higher risk for bleeding. You can stop the Plavix and have them continue on aspirin. And say you get one antiplatelet to at least maintain stent patency, and if that's something that the surgeon will tolerate, that's fine. But I don't think we have a validated scoring system to see from a dual antiplatelet therapy standpoint as of yet.
Chris, you touched on this a little bit, but when you get called as a medical consultant on a hip fracture patient with a troponin postoperatively of 0.07, what's your approach to the patient currently?
So obviously, hip fracture, postoperatively just had surgery. They're on the troponin elevation. Obviously, I'm going to risk stratify them and saying what other comorbidities do they have, what's their risk profile, if they had non-invasive testing in the past. You know, I want to know what about them. So let's see what data they have. If they don't have data, it's not unreasonable to get that data. It's not unreasonable to say if that patient has evidence of ischemia. The other question is you trend the troponin. You want to see where it's going. You see if it does trend down. That's not a patient that we have any data to say an intervention is warranted or necessary. I think that you can have a valid argument to say a low-dose beta blocker predicated on their tolerance is a very reasonable thing to do because they've had an event. Obviously, I'm not starting to Bigatran on them, but I think the question will be what in the other modalities of managing an acute coronary event or acute event, if we call it an MI or not, whatever you call it, what panel of therapies are appropriate. Is that a patient appropriate for a beta blocker and a statin? I think the French study I talked about suggested that's probably a good thing to do. Again, until we have larger randomized trial data, that's what I would do. I would say low-dose beta blocker plus minus statin, risk stratification with non-invasive testing sometime after the surgery wouldn't keep them from, would get them up and move them. But then I think it's really then getting them plugged into cardiology for further risk stratification down the line.
Going forward on that question,
yes.
Do you move the patient? Do you leave them in the ortho service? Or do they end up in your private unit with me?
If they have an event like that, we're moving them to a monitoring unit with a different nursing attention. So we have a different building for cardiology that we will typically move them to. And that's a conversation with the surgeon, with the surgical team, and with us to say, hey, this patient's now at higher risk. We've got to put them in a different venue where they're getting more monitoring and cycling troponins and telemetry. So we will do that. Anything else? Oh, yes. So the question is, what if someone has post-op atrial fib with RVR, what's the post-operative risk for bad events with that? That hasn't been explicitly studied except in obviously cardiac surgery patients. In non-cardiac surgery patients, you know, it's something that we know has a prolongation of length of stay. So that's certainly the output, and that prolonged length of to worsening outcomes. I think it's about a 50 to 60% prolonged length of stay, which makes sense because you're keeping them, you're monitoring them, you're getting the echo, you're getting the TSH, you're working them up for that. You work it up as you would any other, but certainly that's the idea. Was there an inciting event that did that? So cycling, you know, looking for that as a manifestation of an ischemic postoperative event. Again, you know, as I said, a significant number of these events are silent, So if there is any noise that comes up that might be something to suggest that, very reasonable to assess that. All right, one more question. Yes. So the question is, if there's a discordant DASI from just talking to the patient, the subjective assessment. So there should be a correlation there to some extent, because it doesn't, if you're going down the route of asking the discrete questions that the DASI asks, you should be correlated with even the subjective assessment. In other words, you're asking the questions: can you get up a flight of stairs? Can you run up around the block? Can you carry laundry up the stairs, the full basket? So those are questions that do correlate a bit. DASI gives you a structure behind that. So I haven't encountered where there's a great discordance between those. I'd be interested to hear if you have an example of that, but I don't see that I typically see a discordance between those. I don't know if you guys do.